The next session is about AI for clinical documentation. As you know, AI is penetrating into our healthcare systems. AI Scribe is probably one of the best example of the use case in the system right now. So we're very glad to have a panel from healthcare IT to talk about the insights about AI Scribe rollout at Johns Hopkins Medicine. So I'll do a quick intro of our panelists. Today we have Anirudh Sridharan, interim chief information officer, Johns Hopkins Medicine. Deanna Hanisch, vice president and chief information officer, Johns Hopkins Health System. Brian Hasselfeld, executive medical director for digital health and innovation, Johns Hopkins Medicine. Valerie Smothers, director of the Office of the Data Trust, Johns Hopkins Medicine. I think they will tell you a bit about themselves, what exactly they do, what they oversee. I think that will help you understand contextualize their perspective to what they're going to talk about. We want to start with a brief presentation to set the stage, just to talk about general AI Scribe rollout at Johns Hopkins. And this presentation will be offered by Dr. Anirudh Sridharan. Sorry, I'm very bad at this. I practiced many times, but still don't get it right. So pardon with me. You probably can say it again. All right, so without further ado, I'll take it over.
Hi there. So as mentioned, my name is Anirudh Sridharan. I'm the interim chief medical information officer for Johns Hopkins Medicine. I practice clinically as a hospital physician. So I'm trained in internal medicine and geriatrics. Oh, do I need to? Okay, sounds good. Maybe I will figure out how to raise this a little bit. Perfect. Can you hear me now? Thank you. Perfect. So as I was saying, I'm trained in internal medicine and geriatrics, though I specialize in taking care of hospitalized patients. And so really wanted to talk about something that actually Dr. Najjar had hinted at during his talk, which is an example of a large-scale deployment we've had clinically of an AI tool. And this is specifically around an AI scribe. And so what that is basically, it is a tool. Our clinicians mostly use it on their smartphones. So it listens to the conversation between a physician and their patient. It then uses a number of small and medium-sized language models to really do natural language processing on that conversation, and then runs it through a generative AI model to create what looks like a physician note. And what's been really helpful here is that this has been streamlined into our clinical workflow. And so the clinicians have this turned on when they see the patients, and then it's now deeply integrated into our electronic medical record system. And so those notes flow right into the workflow, which Andrew Menard and Dr. Sayre were talking about, which is really important, is that these tools be seamlessly integrated into the way clinicians do their work. And so we launched this tool. We had a probably year-long pilot to figure out what was the best vendor to use, and then launched this back in December of 2024. So we've really had this in use at Hopkins Medicine for the last almost year at this point. And so why do we care about AI scribes? And so, one of the things that is a reality for our physicians that they spend a huge amount of their work life inside the computer system. So usually on average, physician uses the computer system about 5 hours a day. And of that, a quarter of that time is used just in clinical documentation. And as you can imagine, physicians are spending a lot of time actually talking to patients. And so they don't always have time during their work day to actually do most of this clinical documentation. And so really this concept of what's called pajama time has come up, especially for a lot of our physicians that do most of their work in the clinic or office space. And so they were spending an inordinate amount of time in doing clinical work outside of work. So after they had dinner, sort of when they were prior to going to bed. And we have data in our system that show our clinicians writing notes at 8 p.m., 10 p.m., sometimes 2 or 3 a.m. in the morning on days when they're supposed to be seeing patients. And this was taking up a huge amount of time. Nearly half of physicians were spending 1 to 2 hours a day doing this extra work outside of work, and a quarter were spending 2 to 4 hours doing this. And so there really was a need to find a way to make this documentation easier, to reduce that burden on our frontline clinical staff. And our docs that use this really universally love this tool. Our pilot users, of which you see the feedback here, the themes that were really consistent were, one, they really appreciated the ability to really concentrate on their patients, to really give their full attention. As you may have seen with some of the other, in the last number of years, when you interact with physicians in the office, often they're looking at their computer, they're typing as they're talking to you. And as you can imagine, they can't devote 100% of their effort or their attention to you. And so physicians really loved that. The other thing that they noticed, which is a little bit more subtle, was a decrease in cognitive burden. So if you think about it, when you're having a 20 to sometimes hour-long visit with a patient, there's a lot that they're telling you, and trying to document that is challenging. You're making a lot of micro-editing decisions as to how do you condense that hour-long conversation into something that makes sense. What parts do you keep? What parts do you leave? And so the ability for an AI tool to be able to condense that conversation for you, to at least have a draft that you can work off of, was really something that people liked. And then they also noticed, as a corollary, that they were having to do less time outside of work. For instance, a personal example, my wife is a primary care physician. She was one of the first pilot users for this AI Scribe tool. And after about a week of using it, she's like, they could never take this away from me. She was spending a minimum of 4 hours a week on weekends finishing up clinical work. Once she got this tool, she never opened her computer on the weekend, and it's been quite amazing. So obviously, with this kind of feedback, you'd assume that every physician at Johns Hopkins Medicine is using this tool, and they started using it immediately in December of last year. But that's actually not the case. We've had, some really impressive use, but if you look at it, we have about 2,200 of our physicians across Hopkins that have used this as of October of this year. But if you look at active users, that's a little bit less, probably around 1,500 clinicians as of November of this year are using the tool. And how that translates across Hopkins Medicine, probably about 21% of our physicians are actively using the AI Scribe, but it is lumpy. So if you look at our Johns Hopkins Community Physicians Group, which is primary care physicians, they really have nearly 70% of their physicians are using the AI Scribe tool. And that is a combination of things. There was need, obviously. My wife works for Johns Hopkins Community Physicians. She's a primary care doctor, and they were getting buried under this documentation burden. And the AI Scribe tool was really optimized initially for primary care physicians. But we are starting to see increased use across some other specialties. So neurology, for example, at this point, nearly 45% of the neurologists in the School of Medicine are using the AI Scribe tool. But that's a combination of the tool being good, but then having a number of neurologists that were really passionate about getting their colleagues to adopt these tools and really showing them how it fit in the neurology workflow. Another area that's been surprisingly effective is neurosurgery. Our surgical subspecialists have been relatively slow in adopting these tools, but neurosurgery is one where nearly like 28% of our neurosurgery faculty are using the AI Scribe tool. Now, some of the things that are getting in the way of adoption, really, one is that people have used our current electronic health record system for the last decade and have gotten really good at figuring out how to document optimally. I have a neurology colleague who is tech forward and has figured out how to optimize his use of our medical record system. And so he's able to write his notes using that system without using an AI Scribe, without spending any extra time outside of hours, and he's not a great candidate for it. What some other folks are realizing, especially in the subspecialty cases like oncology, that the AI Scribe output isn't quite what they need. They're having to do a lot of editing in order to make the notes work. And so we have a number of early adopters, but haven't really seen mainstream adoption there. And then there's some places where really the workflow needs to change. The tool needs to improve. So when I speak to emergency department physicians, why they don't use this tool as often as they could, if you think about the emergency department workflow, the ER docs end up seeing a patient, they come up with an initial diagnosis, and they'll write an initial note saying what their impression is, but they like to update their notes. So when lab tests come back, let's say someone comes in with abdominal pain, they get some blood tests, they get a CT scan, and they like to update their notes. And the AI Scribe tool sort of writes the note one time, but doesn't let them update it when new information comes sort of automatically. And so that's something that they need in order for this tool to be effective in their workflow. The same thing for hospital-based physicians. A lot of our notes are really the patient-physician interaction is probably 10 to 15% of the content of our note, but a lot of the other things come from lab tests, imaging studies, what other specialists say about our patients, what the nurses say about the patient, and that doesn't get captured when we're just talking to the patient. And so the notes aren't quite what we need in that space, and there needs to be some work there. And another space that's really interesting is some of our specialists that work in the office ingest a lot of information about their patients, previous CT scans, previous tests, previous interactions they've had with previous physicians. And that obviously doesn't get captured when you're just talking to a patient, and trying to get all of that into the AI Scribe is not there yet. These are things that our AI Scribe vendor knows about and is actively working on. So there is a movement to get more specialty specific notes. And we have a number of our early adopters across many subspecialties that are testing these notes, whether they be in orthopedic surgery or vascular surgery or oncology, and trying to improve those notes so they make more sense for those kind of docs. Another area that's really important that the AI Scribe vendors are really figuring out is that we need, like a lot of language models, you need more context. So more patient information, stuff that's patient information that's outside of just that doctor to physician visit is really important to make these notes as useful as possible. And then there are downstream tasks that physicians need to do once they finish seeing a patient. That's placing medication prescriptions or diagnostic tests, or helping with other clerical work like physician billing. And those are areas where these tools could become more and more useful. I know I gave you guys a lot here, but happy to hand it over to the panel here and answer some questions based on all of that priming.
That was great. I wonder if we should start with a very quick introduction about your sort of your job. I think there's this maybe it's hard, might be difficult for people to make sense of it just from the title. So maybe talk about what you oversee, how this play into your job.
Sure. Since I did all the talking first, I'll just continue that trend. Can you hear me?
Yep.
Okay, perfect. Yeah, so I'm the Chief Medical Information Officer, so I'm a physician, obviously. What I feel like my role is in applied informatics. So I really oversee a number of other physician informaticists that help with the deployment of our electronic medical records and other associated information technology tools at our various hospitals and at our large ambulatory network, the Johns Hopkins Community Physicians. And I work in really close proximity with Deanna Hanisch, who's our health system CIO, because I feel like our physician informaticists can't accomplish anything without health IT and the large team that Deanna runs. Oh.
I'll go next.
Yes.
Hi, everybody. I'm Valerie Smothers. I'm the director of the Office of the Data Trust. The Data Trust has oversight over the use and disclosure of Johns Hopkins Medicine patient data, and that's in many different contexts: research, quality improvement, and operations. So I'll talk a little bit about the governance of AI and the role the Data Trust plays.
Brian Hasselfeld. I'm a primary care doc, boarded in medicine and pediatrics, and practice primary care also through our community physicians group, but spend most of my job as our executive medical director over digital health and innovation. largest team is overseeing technology-enabled care at a distance, so all of our telemedicine, virtual care, but also working closely with this team here at the table to think about ways we can use technology to innovate our care delivery, and sit in one of our clinical operations offices in the Office of Johns Hopkins Physicians, which combines a lot of kind of practical, clinical, and operational teams together in the direct delivery of our care.
And hi, I'm Deanna Hanisch. I am the CIO for the Johns Hopkins Health System. So in that role, pretty traditional, but I am accountable for all of the software that is deployed that takes care of our patients and all of our caregivers. It also incorporates just kind of like the running of the day-to-day of the hospitals and the community practices. So I get to work quite a bit with this very multidisciplinary team, which is a really fun place to be, as we're especially in this new landscape, which has really shifted our jobs in the last couple of years.
Great. So I have prepared a few questions, but I also encourage the audience to, if you have questions, we will open up toward the end. So I want to start off, because earlier in the presentation talked about adoption rate. So the vary depends on the specialties, the different divisions, and talk about, you also mentioned a little bit about the barriers that cause that. Maybe comment on the flip side of that, like what strategy have organization push to encourage adoptions, education workshop and all that.
Sure. Specifically about the AI Scribe, how we're trying to drive adoption. Mm-hmm. Yeah, so I think that I view this like any other discontinuous innovation. And so there is, part of it that is around marketing. And one of the most powerful things is people love to hear from folks that they view as their peers. So we really try to identify with the data that we have who are early adopters of this technology in different specialties, and try to figure out who are unofficial leaders in a department, someone will listen to and say if something is worth it, they'll actually listen and try give it a chance. And so we really try to cultivate those folks across many different specialties and collaborate. The question I always ask first is this ready for your colleagues, your mainstream colleagues? They're folks that are the most conservative in adopting technology. And when they say yes, then we really try to make a big push in those departments to get folks to give this a try, figure out ways to reduce barriers, figure out anything that we can to make it easy for folks to start to use the tool. Because that we have seen that once folks get a taste for using this technology, it's really sticky. The question is just getting them in the door first and getting the right people to convince them to get in the door.
I already see some interest, but I have a few questions I want to go through, but we'll get back to the audience very soon. So I want to touch on the measurable impact. So earlier comment on subjective perceptions, providers love it. So my wife also working in primary care, she also love it. So I wonder if you can give us any insights on any measurable benefits that this is bringing in terms of maybe time save or quality of the notes and all that.
I'll hand it over to Brian. He's thought really long and hard about the impact of the AI scribes.
And thanks, Anirudh, and thanks to the data teams and the informatics and IT teams that have really driven the data aggregation. It's well published at this point that we are seeing incremental time savings in documentation, what Anirudh already mentioned on decreased time in notes. Internally, we have started to see a trend towards increased productivity, so improved coding on a per visit basis. Some improvements in time to closure of notes, although as Anirudh pointed out, I think with every tool, there's kind of what is the marginal gain per user. And so those that have already highly optimized their documentation workflows to their specific subspecialty, even if the tool fits well, the overall gain for that individual user is less. So actually, the lower adoption in some of our data have been those that are already really good at notes, which makes sense. So kind of your pre-existing state matters, even if the tool is overall good for your particular workflow. I think what will be interesting to see is, how does this tool evolve over time as additional features and functions are added, which expands the scope of the benefit as we move forward. And I think we'll get into that here shortly on kind of the art of the possible once the clinical encounter is digitized. That's what's happened at the core for this tool. And if you're now, I missed Dr. Najjar's speech, but I'm sure he used the word sensorization once or twice. But If you've now sensorized that live verbal conversation between clinician and patient, there's a lot more that's possible, and we're starting to see that on the roadmap. So I think early gains in time savings, but we're in debt to our clinicians in pajama time and work and documentation burden. Once we get out of that debt, I think we'll start to unlock some additional uptake here.
Thank you. I will take the liberty to ask one more question. So I want to give people enough sense about how big this team is actually managing. So we will, I think some of the audience question will be on AI Scribe specifically, but before that, I think maybe talk briefly about, zoom out a little bit, talk about the AI portfolio that you are overseeing and how the general AI strategy and policy and governance play into those decisions.
I'll take that from a high level. I can tell you AI is playing an outsized role in everyone's conversations, but getting that conversation into production is a long journey. So interestingly enough, I'll start by saying 5 years ago, if you had told me we were going to pilot a bunch of things, to turn them on in production with the intent just to see what would happen and then turn it off, I would have laughed at you. It's too hard. It takes too much IT bandwidth, too much change management to do that at a rapid rate. Today, I know this thanks to board meetings coming up, we have 8 AI tools in full production. We have 21 pilots in some degree of process. 3 years ago, you would never have heard that volume. And more we're saying we just have to turn it on and see, is it good enough? Is it not good enough? We also have to have the discipline to turn things off. We have to figure out where our risk profile is. If we are estimating length of stay or a date of discharge that someone's still going to look at, that's probably not quite as risky as if we are diagnosing a patient and not having anyone look at it. So our risk profile is really different. We're trying things out in a bunch of different areas. Our teams are quite large, but most of the tools we're going to end up deploying are going to be something that we buy. We're going to be looking at teams of computer scientists and experts that have please worked with clinicians to come up with a great product that our peers are working on at the same time. And those are going to be the areas where we're going to gain the most ground the quickest. But right now we have the most risk tolerant in anything operational. If you can give me an ROI on the billing side of the world, chances are we're playing with it more and more. But the exciting thing is, and a lot of the things that most of us go into this line of work to do, is to actually really improve the patient experience. And we get to see those as well. So that's my high level answer, but I'm sure my colleagues have more.
Here, I can say, yeah, I can talk a little bit about the governance. So we had an existing governance process for new software being deployed at Johns Hopkins Medicine. And what we did was we took that's called the Software Implementation Program, SIP. Yeah, close enough, SIP. And we said we need to take that and add in an AI governance process. We created some AI governance committees. We have clinical, imaging, and operations. And when proposal to implement a new program comes in and we identify it as AI, it goes to one of those committees. And we have clinical experts and operational experts on those committees, data science experts, people with ethics backgrounds. And we ask them, does this meet our principles, our guiding principles for the implementation of responsible AI? Do we need more evidence on this? Do we need to have a pilot on this, as Deanna was saying? If so, we get a pilot, we look at the evidence, and then they make a decision as to whether this is something they think should move forward in the process. They have the ability to blackball it. They have the ability to endorse it. But our software intake process can still say it's not going to move forward. It's a larger conversation than just, is it responsible? Is it meeting our guiding principles? They have to look at things, the legal, financial, and whether it's duplicative of other resources that we have. So it's integrated into a larger governance process.
Great. I already sense the eagerness of the audience to ask questions. Harry, are you Yeah, go ahead.
Is this working? Oh, yeah. It is. All right. So I have a bunch of questions, but I know there's a lot of people that want to ask questions. I'll try to make a lump of them. One kind of philosophical question, but I'm a little bit confused by the pajama time. Because why is it that people are spending weekends doing work that they should be doing during the weekday? Like, is that not factored into clinical practice, right?
Yeah, I mean, I think well-published study from some of our colleagues at Mass General Brigham that if you added up the amount of time for a primary care clinician with a full schedule, they need 24 hours to do all of their required, 25 hours in a 24-hour day to do all of their documentation work. When we see someone for 20 minutes, when we're covering 30 to 40 different medical issues, and we're trying to document for really 3 big reasons. Obviously, we want to document for clinical care reasons, but we're also documenting in a highly litigious environment, in a medical legal environment, and we're documenting to get paid. All 3 of those things kind of drive increasing complexity in the documentation burden. And then beyond that, a few of us were chatting after the fact that kind of the single problem visit type approach worked better maybe when there were a few things to talk about, but medicine has become increasingly complex. The amount of diagnostic and therapeutic options and amount of complexity that sits underneath that is significant. And I think we've fairly outstripped our ability to care for a single human in that amount of time.
Yeah, which I understand. I feel like that systems wide, right? Like you would think that if it takes that long to add documentation over the years, you would try to squeeze that into your work hours, but it seems like you all are required to see the same number of patients, but then do the documentation in addition to that, which sucks. Okay, so one other question. So I was curious about like the discrepancy between, again, community practice and the Hopkins practice, and then what might be driving that? Because in the imaging field too, I feel like maybe there's a parallel in that in the academic side, you have residents and fellows that, preview studies. So there might be less of a reason to use some of the AI tools, like, for example, I mentioned. And then I noticed that like about 10 to 15% of the users don't convert to active users. So they try it. Is there some kind of reason why? Is there a consistent reason why, or is it just individual random?
To the first part, but when we've looked at the data, our community physicians group are 80 to 90% clinical, meaning most of their job is to be in the clinic seeing patients, and predominantly in general medical care or general medical specialties. So primary care, general neurology, cardiology, endocrine, and pulmonology. So the more patients in a day, the more documents to get done. Obviously, the total aggregate benefit over the course of the day adds up with that higher clinically active individual, but also ties more to the initial development of the product, the general medical specialties and primary care. Interestingly, when we look at our residents who are School of Medicine residents, but go to different sites, they adopt the usage patterns of the attendings that are with them. So it's the same cohort of resident clinicians in the School of Medicine. Some are at an academic site underneath faculty, some are at a community site underneath the community physicians, and their trends of use kind of follow that really highly active, high throughput churn of the community practice versus a little bit of the less clinically active faculty footprint. So I think both of those are weighing in right now, both the medical discipline and the high volume clinical.
I have a simpler answer. The technology is not good enough yet. So you see the adoption where the technology is good enough. So there's 2 components at play. There's the tech, and then there's the willingness to change of the users. And we're all self-interested. And I think it's no different than tech in your own life. You knew Facebook hit mainstream when your grandparents were on it. The iPhone is easy to use when your 2-year-old can use it. And I think you want to take the same concept here in technology. This tool worked phenomenally for primary care. It was designed in that space. It fits the context. It's the beginning and end of the visit. It's all complete in the conversation. When you look at how Anirudh rounds, which he'll be obviously much more articulate to explain, it's not that cohesive. And so it's a different context. The tech output isn't as good. It's not as specialized for a subspecialty urologist. It doesn't do what a human scribe does, like queue up the notes and pick up a paper chart. And so there is a technology, it's just not there yet. You'll see the adoption there when the technology gets there too. So I think we have to keep living and pushing. It was phenomenal, it was really exciting, and then it hit a ceiling. And now we have to wait for it to keep going.
Thank you.
Go ahead, maybe introduce yourself, your background, and then the question.
Hello, I'm an MBA student at Bloomberg School of Public Health. I'm a digital health fellow on the Center for Global Digital Health Innovation. I'm doing a broad scoping review of ambient AI scribes. I'm currently in the process of screening 15,000 articles, but it's growing by the day. Every day, 30 to 40 articles pop up from nowhere. And I think there's a lot also in the pipeline coming around. I'm just wondering about the extraction and the scribing, because what I heard and I realized from now is that when you let the AI extract information from the clinical context, go through the EMR, and have some context prepared before going into the scribing, I think it'll make more logical sense in a continuity. So is there any article around that? Because I didn't really read that part, but maybe it's in the pipeline. Maybe if you have any implementations coming around about data extraction from the records and using it in the AI scribing. Thank you.
I don't know if there's an article about it, in part because that next step in integration is just being implemented right now. So a lot of this comes down to the AI scribes are really interesting because they could innovate outside of the EMR vendor. So they were able to innovate over just a conversation. They had to use NLP and diarize it and then create the note. What they're working on now is actually pulling out the right context from the medical record, whether it's Epic or whether it is, I almost said Cerner again, whether it's Athena, et cetera. You have to pull out that data and now integrate it in. And that's really where we are generationally. So all of the tools are just making that context available now-ish. And so it's going to take a little bit for the articles to catch up.
Thank you.
Go ahead.
I have a background in engineering, so I'm trying to merge the two. With regards to bedside patient care, in terms of the tech's job and the nurse's job, what I see is that the nurses and the techs, they have so many different technological devices that they have to use. The nurses in particular, if there's a language barrier, they have to get that machine to help with the translation. For instance, with the distress call button, we have that available to us as well next to our badge. We have the phone that we need to use as well to contact anyone and to take pictures of the patient. And then there's the AvaSys system that we implement as well for patients so that we can keep an eye on them. So I feel like with all this technology, I feel like something that would be complex but yet beneficial, and I know it needs to be researched some more, but I'm thinking something along the lines of like a body cam for the nurses and possibly the techs as well, but mainly the nurses, that has this capability, the scribing capability, the translation capability, possible distress button on there. It would help improve patient outcomes as well. And it would give us a live view as to the care that's happening. And definitely liability issues will be addressed there as well in terms of lawsuits. I think that's something that needs to be taken a look into. It works for police officers.
I mean, I'm happy to take a stab at that. So it is, you are right that our nurses and other staff are inundated with technology in many different devices. I know that we are baby steps, so don't wish to overpromise where we are right now, but yes. We have been implementing Hopkins on a pilot basis on many units, what we call a virtual nurse. And so that technology is very dependent on having a camera and a microphone and being able to do that. And you could see it's not too hard to connect the dots where that camera and microphone could be used as ambient technology to be able to record the visit and interaction between the nurse and the patient to help with, it is not just physicians that have documentation burden, but nurses and techs have to document a ton, not just vital signs, but the sizes of wounds and so many other different things that could potentially be automated through both video and audio technology, and really try to relieve a lot of that cognitive burden and tedium that we really imposed on our staff. And I know, again, referencing Dr. Najjar and sensorization, there is obviously the ability to do some of this with just visual technology, being able to mark some of these critical nursing and tech tasks that they're now having to manually document, being able to do that automated. But yes, there are many steps between what we have now and that vision of making all that care a lot more automatic and easier.
Okay, thank you.
Go ahead.
Hi, I'm Gurmeher. I'm a BI manager with Johns Hopkins Health System. I think AI Scribe works really well in the outpatient space, but as soon as you come into the inpatient side, we are now in a very tricky space because you could probably have unintended consequences, because we could start capturing diagnosis codes or other information that we may not realize leads to coding of certain elements that leads to bad regulatory outcomes. For example, like hospital-acquired conditions, the AI Scribe, you might document certain things, you might then start coding them, and you won't realize that impact on what that coding is doing until all that data goes through processing and everything else happens. Then you figure out, oh, Johns Hopkins Health System is losing $10 million for complications through the regulatory lens. Same thing with with AI Scribes. You want to with a lot of patient notes, you try to optimize them for something like mortality. Like you want to if you're putting in the BMI and you're saying the BMI for the patient is 30, that usually in a lot of models does not mean that the patient was obese or not. So the clinical documentation nurses reach back out, ask, was the patient obese or not? And that leads to more queries. So my question is around that unintended consequences. How would we measure and understand that impact as it kind of comes into the inpatient realm? Because it can be a lot of money that you end up losing then.
I'm happy to take this as an inpatient physician, and other people can chime in. I guess I view it in the other way that these tools could probably help make our documentation more complete. It may not just be the AI Scribe technology. I would say that, especially in the inpatient space, I think that there is something that we're actively looking at is chart summarization and being able to get more of the context of the patient's health record summarized and potentially help in helping our physicians be more consistent in documenting these conditions. One of the things that Governor is talking about is around marking conditions as present on admission. So that is really key in clinical documentation. So an example would be getting a bed sore. So one area that we've always had challenges with is that sometimes 3 or 4 days into a hospital stay, a nurse or a doctor may start documenting that someone had a bed sore, but really they actually had it from when they came in. And there's a big difference in the hospital quality based on when that condition was first documented. And I think that we have the scope for being more consistent of being holistic in all the conditions someone arrives to the hospital with. And so we can be better at assigning credit or blame on what develops since they get to the hospital. So my view always is glass half full. So I hope that we can use this technology to help folks not have to be more complete in their documentation without hopefully adding more effort to their work lives.
Thank you.
The fender was spent when you rented the car.
Yeah.
Hi, my name is Donald. I'm a PhD student in the Chemical and Biomolecular Department. So as a former human scribe myself, I'm curious at how well these AI scribes compared to human scribes. And I wouldn't be surprised if they're a lot better than somebody who's, like a 19-year-old kid who never went to med school. I also was curious about how good it is at filtering out information, because I know lots of times you might have a 10-minute conversation and you only end up writing a paragraph. I guess I was just curious if they write really long and drawn out reports that might be hard to sift through, as opposed to maybe a more concise note.
I'm going to start with the first easy part of that and hand it off to the docs for the second. It shows up on time every day. It does not call out unless AWS is down, and then we're all in a little bit of a world of hurt. So it is much cheaper than you are as a human sitting there, and much more scalable. But it isn't as smart as you are as a human scribe. You can talk to your physician, you can queue up orders, you can understand the context around it, you can personalize a little bit more. And so areas that we have seen the AI scribe try and replace the human scribe, and I keep looking over here because Dr. Najjar is a surgeon, he will tell you, the surgeons don't love it. It isn't replacing the surgeon's AI or the surgeon's human scribes yet. The same is true in the ED, except in the area of cost and reliability. It's not quite there. It doesn't have the full functionality. But in a lot of cases, it's already winning the race. I'll let the other doc guys.
When we compared two different vendors early on in our scribe review process, I think one of the things that stood out was an early move to some semblance of individualization around the tool. So do you like your notes shorter in bulleted format? Do you like it in this or that? And that's kind of what a human-to-human interaction is able to do. You get to learn very quickly how this clinician A versus B likes to document and craft their notes. And so I do think there is a trend towards individualization and how the scribes are building up their product suite and portfolio. But the point still stands that when a human walks into a room, most of our interaction is visual and multimodal. I'm married to a procedural dermatologist who will never give up her human scribe, because the scribe can also see this procedure tray was set up, these additional components were visualized, these different aspects of the skin were seen, all without having to verbalize and vocalize. So, I think it's the areas where there's multimodal, information that's coming into the human brain, where we're still not quite there yet in a audio only context. But I do think the individualization mattered a lot in our early selection.
I guess two things. I'm never above pandering. So one thing that humans are way better than LLMs are is that humans can learn really quickly. So a human scribe definitely can get feedback from a physician really quickly. We are really efficient at learning compared to large language models, where it's really expensive to be able to retrain them. The other aspect, as far as what you were talking about, as far as how good the AI scribes are at summarizing the conversation. We do have some levers for that as far as whether we'd like the note to be comprehensive or brief, bulleted. So we do give our physicians that little bit of sort of configuration. And so there is a little bit of that. It is interesting. Different docs have different predilections. So some people feel like it tunes out too much of the sort of chit chat and social interaction, which they like to document in their notes. So there is a little bit of a push pull as to how concise these notes should be.
Thank you.
Russ.
Yeah, hi. I'm Russ Taylor. I'm a professor of computer science and a few other things, including I've got some med school cross appointments. I have a question about learning curves. In my experience, anytime you introduce a new technology, especially into a process, there is a period before it's being used effectively. And this is true both for the individual. If I suddenly am given a new tool, it takes me time, but also in a way for the organization and the institution. And I'm wondering if you all could comment on experiences with learning curves And since a lot of what we do is a trial and to see if something is going to be useful, how we account for that in making our assessments.
I'm sure Deanna probably has a comment, but I think what was a little perhaps different, and what I think probably all of us push back on a little is kind of assuming that things that are true for Scribe are true for AI in healthcare generally. I think a few things were different and unique for AI Scribe. One, the paradigm that someone else is writing a note that you review and further refine is one of the most common paradigms in how we all learn and educate in medicine. And so kind of that replication of that process is something that we started with from the very beginning. And the second aspect is that the tool really didn't need much additional education and training and about how to incorporate that pre-existing paradigm into your clinical workflow. Something that anyone that's supervised a med student, a resident, been a med student or a resident knows quite well.
Yeah, that's for that specific
right
tool, but there are other tools that we deal with. I'm sorry, go ahead. I want to hear the other answers too.
Sure, I'll expand it. I think we're all learning what our expectations are and how to work with it. And I think that's been a really big shift for us. So I'll flip over and talk about summarization, but we can also talk about billing workflows, et cetera.
Yeah.
I think what we're seeing is we first often start by a small group of folks who are willing to change. If you don't have a willingness to change, your learning curve is going to be really hard to overcome. And one of the great things is there are so many painful workflows in healthcare that we have lots of opportunity to work in here, right? So what we're really looking for is any place that is ripe for disruption. And when you take healthcare as a whole and you kind of break it down into its parts, whether it's summarizing a chart of, I don't know how many data points exist in one Epic chart, but if you have a sick patient, it can be, you're going to miss things in there. So you start with a group of people who are willing to think through, could I adopt this workflow? And so we just recently have been partnering with Microsoft to redo our blood clot classification. Are they high or standard risk for blood clots walking in the door? And we spent all of this time coming up with a model that we could accurately predict whether you're higher or standard classification. We proved it, and then we handed it to our first group of 20 users, and they said, it's great, but it's a pain to do over here, so we're just going to ignore it. It doesn't matter if it's better or not. And we learned this lesson over and over again. We had to redesign the entire workflow and then try again. And when it gets there, it makes it much easier. So I think to answer your question in terms of individual users is, do we have a group of people who believe and think, can we use it? And once we get there, then it's a lot of work of our informaticists to figure out how do we now actually get the entire system, the entire specialty to move and to row in that direction. And that's a very boots on the ground approach, often by trusted colleagues.
And I'll just add, we've talked about the need for some general AI training for clinicians in the health system. That's something that we're working on. We think having a little bit of a floor there from a training perspective is going to help in terms of adoption and ensuring that people aren't overly dependent on the AI and not implementing critical thinking.
Okay, well, that's interesting.
Go ahead.
Okay, well, thank you very much. This is a very interesting area to me because I've tried to get new technologies in the past. Thank you.
Okay. So I'm Sunil. I am CTO of a company called Empower AI. Actually, first of all, thank you. This was a wonderful introduction to the Scribe. I hope those guys are paying the bill today. You mentioned, I think like my question is kind of twofold. One is like you mentioned 8 tools deployed, I think if I heard the number correct, and about 21 in the pilot stage beyond Scribe that you guys going after. And are there any tools which are really taking care of the unified care navigation all the way from the hospital to the discharge to the home system and so on, so that like people don't fall into the cracks?
there is a tool out there for everything, and there are 20 companies out there for every tool. So I think the short answer is yes. The real challenge is how hard it is to integrate into our existing EMRs and how much the cost is going to be when you start looking at those. So when I mention those tools, about half of those are Epic. If you look at our peers, they're saying, we're going to take the tools that are easiest and already there to start to play with. And then we're really looking for the high value tools outside of that can really move the needle. So in our case, our Bridge Scribe was that for us. We're looking at summarization tools that we think will do it a lot better than our EMR. We're looking at those things. I think to answer the direct question about care navigation, I've seen a lot of tools out there in different pieces of it. But really where we are in the learning curve is we're seeing a lot more point solutions than full platforms. And that's going to keep us more nimble until the industry matures a little bit more.
So what is the process for a tool to come in?
We have one of our clinicians, there has to be an advocate within JHM, someone that thinks this is a tool we need, and then they have to submit a proposal for the implementation of the tool, and that gets reviewed through the software intake process, which I was discussing earlier. And then if it's AI, it will go to one of our AI sub-councils that determines whether or not it's sufficiently aligned with our guiding principles. And if that's a yes, it can move forward in the SIFT process. If it's a no, it doesn't move forward. Moving forward in the SIFT process doesn't mean that, yep, we're going to buy it, it's approved. It has to be aligned with need, right? That you've heard Dr. Sayre, Andrew Menard, many others talk about the need to align with what our clinicians need. And on the operational side, what we need operationally, what is aligned with our priorities. So that really drives the decisions about what we're going to implement. But just to start with, there has to be someone at JHM that is willing to play a role of advocate and to put this into the process and make the case for it. And then we'll look at the evidence supporting its implementation along with other things.
Yeah, and you know, I think the question around something like care navigation is actually a fairly common question. But I think the question on care navigation, would it be something like, can it be done? I think all of us can easily understand why the current state of the technology could reliably be a good care navigation partner for a patient. But inside a system that sees over 1 million patients every 12 months, that has 6 hospitals and 1,000 plus data points in the last few weeks to months for those patients needing care navigation, the question is, does it work? Is it practically usable inside of the multiple human teams that are doing their best to care for that same patient? And are we going to fragment? Are we going to further fragment or increase reliability, safety, and quality underneath that tool? It's not a question of is the tool smart enough. It's how do we fit that tool or completely redesign our processes if they're the wrong ones. But it's the practical implementation questions, I think, right now, not so much can the tool do it.
Thank you.
Yeah, go ahead.
Good question here. Thanks for the conversation. Danny Kiase, part of a startup in the local ecosystem, part of Techstars, so on and so forth. Question twofold. The first is, so we talked about notes being used for this trifecta, right? Clinical care, medical, legal, and billing purposes. I'm curious to what extent, and you talked about how your PCP colleagues, they can't imagine a world without it. I'm curious to which those dynamics lower the bar for them to have to demonstrate a financial ROI for the health system, because it's satisfying this latent desire by physicians/clinicians. So that's my first question. My second question, and if you can touch on this, if not, no worries. To what extent has it affected the malpractice exposure at Hopkins as a result of incorporating these scribes? Thanks.
I'll take the financial one. It's often my job to decide and to work through with our colleagues on what we're going to pay for as we get it installed. In this particular case, we've learned to in this particular case, to be really honest, as we were piloting, we included a lot of our clinical leaders who are still practicing in the pilot. It was our way of trying to justify that this is worthwhile. Sometimes when you look at tools, you're looking for a true positive return on investment. We weren't looking to make money on this. We weren't looking to increase our revenue. We were looking to kind of break even or at least make it affordable. And so we didn't ask, and we've taken a different approach from a lot of our peers, but actually more and more of our peers are following or have our similar, is they're really looking at it as a need and as a competitive tool in recruitment and retention, as well as anything else, and just trying to keep it steady. 2 years ago, we were all figuring out, can we ask Brian to pay X $100 a month out of pocket for said tool? And instead, many of our organizations and our peers across the country have decided that just like we're not asking them to pay for the EMR out of their pocket, this is a core part of the tooling. To the medical legal, I might actually hand it to Brian. Or
Go for it, Brian.
I don't think the data is in yet, although, again, referencing our good friend, Dr. Najjar, who's has a prominent role in our medical legal quality space. My gut sense is that we'll have probably net positive kind of endpoint from that, given the riskiest thing is something that's not documented that ends up becoming an issue that you can't refer back to kind of ground truth medical legal. Obviously, the opposite will be true, that we will have documented something that wasn't actually true. But having used Scribe for 1.5 years in 95% of my visits, I think on the balance, we're including more of what is actually talked about in the note, and I think that'll probably benefit our clinicians in the long run. But we'll see.
Thank you.
I think we'll just take a final quick question and then maybe connect offline. Okay, go.
Hi, my name is Roy Adams. I'm faculty in psychiatry and computer science. My question is about monitoring, which is of interest to the field and to FDA in particular. And I wanted to ask how we're approaching monitoring specifically for AI Scribe, but in general, I'm interested in how you all are approaching monitoring for tools like this that affect the entire health system and can impact patient outcomes in a very diverse set of pathways.
Any of you want to come up with a company that could solve that problem, that would be fantastic. It is a vexing one. It is incredibly complex to work through the monitoring. I will tell you the process answer, which is AI scribes give us the advantage of a human in the loop, with the goal really being that our final checks are our physicians, and they are, at the end of the day, accountable for what note is in place, and their signature happens on it. If they don't sign it, that note is going to go away after, I believe, 30 days, and they'll have to document it on their own. So they are really ultimately our check on it. And a wonderful thing about Hopkins is our physicians are great at feedback. So I promise you that they are pretty good at sharing with us when things are going off. We do basic things like we've had compliance audit the notes just like you would for any other tools. But in terms of really good monitoring of these tools for drift, we don't have a great way of doing it as a customer. And frankly, we don't have the expertise centrally to do it all. So a lot of these are dependent on our vendors to do so. And I think we as an industry are still grappling with how we're going to do it more and more. When it's our own tools and we've built them ourselves, we're accountable. When it's a vendor tool, we're often relying on our vendors. And then we're looking at proxy measures to catch the monitoring, which isn't a satisfying answer for me or for anyone else, but I think that's really the state that we're in. And so it's kind of a continual evaluation, but it's much more process and much less sophisticated than I hope it will be in the coming years.
We have one question from online, just really quickly.
Sure,
This is
go
from
ahead.
Dr. Kimar Green, former Johns Hopkins neuro-ophthalmologist and now founder and CEO of NeuroAgent AI Inc. and Hazy Eyes Inc. He'd love to get your perspective on clinical documentation models. Many health systems are increasingly relying on third-party AI scribes to generate notes. Do you see that as the correct long-term model, or do you think institutions should instead, or additionally, be developing their own EMR-specific data sets that allow notes to be tailored to the institution's workflows and patient population?
Yeah, I think that there's a theme in there from Kamar, and great to have Kamar on the line. I think there's a theme in there that is highly accurate, which is healthcare is local and individual, and I think that that's important. But I think that's balanced against the cost and time to development of what is ultimately a fairly generalizable use case of a very powerful LLM tool. And what we would trade off likely in capability, sophistication, time, compute, and advancement to get the localization and individualization of something that's more homegrown is probably way off balance and skewed towards kind of lack of advancement relative to the gain from the individualization. So I think that would be an ideal state, but build your own in something that is really a small incremental move off of a generalizable model seems like a large jump for any one institution.
I do think the industry is going to move I think that there's the individual provider individualization that's happening right now in these tools. And I am a big believer in the more sophisticated, we need companies pushing the boundaries here. I do think there's going to need to be the space for system controls, just like we have in our EMRs or our ERPs, where the system sets, here's what our expectations are for these types of things, and let the system set some of those standards. We do it for our own clinical decision support. We don't let a third party dictate that. In fact, we struggle when they try to. And so you're going to see more and more of that need for differing layers of specification and for the ability for the systems to put those influences in. But I think it's going to be at the system level. It's going to be at kind of all the different levels we have today, whether it's the system, the specialty, the individual provider. But I don't think it means we all have to create our own. I don't think it's fully scalable.
Great. Thank you all for the engagement. Thank you all for the insights and expertise. So let's thank our speakers again.
You all so much for joining us. This has been absolutely fantastic. I'm very sorry to cut off any further interesting conversations that are going on. I will be brief so that you can return to them if you choose. First of all, I just want to give a huge thank you to Chen Ming and to Michael and to the rest of the committee who organized, the faculty committee who helped organize this. So huge thank you to the faculty. Of course, also, this could not be done without the amazing staff of the Malone Center. I see many of them here, Kelly, Laura, Jamie, Taylor, et cetera. Thank you so much for your efforts in putting this together and your support of the Malone Center. I will say just a few words of themes that I heard come up repeatedly today, just to kind of process my thoughts about what you all talked about. One thing is really thinking about the whole system, right? So the theme was human plus AI, right? But it's a bigger system. It's the patient, the doctor, the overall hospital system, the insurance systems that we're working with, and the technology that we're using. It's not just how well does AI perform in a NeurIPS paper or in a plot, right? Or on an accuracy metric. It's how does it actually operate in a patient and healthcare setting? And that was emphasized over and over again. And those two things may look very different. So the need to really consider how it works in practice is probably the biggest theme I heard today. So thank you all for emphasizing that. Another theme that I heard was trust. I heard this in the first session. I heard this in the discussion we were just having at our table. But the question of how do you establish trust? Trust of a patient with their doctor, it's a long-standing question, something that many of us have learned to very much rely on our doctors and their guidance. But now that we're introducing AI and technology into that, how does a patient trust an AI system? How does a doctor trust an AI system? And how does that work in this three-way and larger environment? And I think that's an extremely important question that we're all grappling with. And the last, I just want to sort of think about how this all fits in from Peter's talk. How do we deal with the gap between what we think we should be able to provide based on what we know scientifically or technologically versus what we actually are currently able to provide in the system that we work in, and how we bridge that gap? So those are sort of the three things that I'm taking away and thinking through as I leave this amazing day today. But finally, again, just want to thank all of you for joining, the students and postdocs and trainees for their posters and discussion. So thank you all for being here, and I hope you'll stay for the reception.
I am pleased to close us out by talking about the Symposium poster session winners. So thank you to everyone who cast their votes. We have 3 posters from the morning session and 3 from the afternoon session that we wanted to recognize. And if I call your name and you're still here, you can go up to the desk over there towards the entrance to receive your winnings or your prize. I'm not exactly sure what we have in store for you. So from the morning session, don't get your hopes up, everyone. You know, it's mostly the nice recognition and such. From the morning session, we have no particular order. Donald Kramer presenting Donnie Deep Omics Neural Network Inferred Expression. So congratulations to Donald. If Donald is still here, we'll give a little clap. I've got 6 of these, so you know we can keep the claps tight and short. For the second one we want to recognize from the morning is Iris Jung, de novo design of alpha synuclein fibrous inhibitors for treating Parkinson's disease. So I have seen that poster and I still don't know how to pronounce it, but well recognized. And let me just read the rest of these and then we can clap at the end. Kendall Reed, do machine learning and traditional regression models identify the same influential risk factors? ? A case study of virologic failure in people with HIV. And then from the afternoon session, we have Malone postdoc Amama Mahmood, reimagining behavioral sleep medicine, designing conversational sleep diary and visualization tool. We have How US Sun, KM GPT, an automated pipeline for reconstructing individual patient data from Kaplan-Meier plots, and Matthew Farah, a novel quantitative method to evaluate functional impairment in patients with Parkinson's disease and other movement disorders. So round of applause for all those who we're recognizing. And with that, I can't thank you all so much. I can't thank you all enough for coming, for putting up with the temperature outside, which has become at times the temperature inside, close to the walls of this room. Been a lot of fun to organize and see everyone here. So hope you all enjoyed it as much as I did. And with that, we will move to either continued conversation if you like, or reception. Thank you.